one of the rheumatology physios based at Barkinghaven and Redbridge. So my main site is King George Hospital. And today we're going to be doing a session, a bit of a spotlight on axial spondyloarthropathy. It'll be an interactive session, so please do just say hi in the chat if you haven't already. And as we go along, I'll be asking your kind of views and knowledge on the subject. I just want you to just put the first thing that comes into your mind as we go. So I'll guide you as we go along. If you've got any questions, by all means, pop them in the chat, but I think I'll pick them up at the end of the session. Okay, great. Here we go. So this is where I can't progress my slides. Oh yeah, we can. All right, fab. So what is this rather long word? I'm going to have a few of you, whoever's feeling brave, can you just unmute yourselves and see? I want to see what people's pronunciation is like of this term. So can you say the S word? Anyone who's feeling brave, just unmute yourselves and have a go at that. Nice
Axial spondyloarthropathy.
Great. Anyone else? Go on, one more. Give us a go.
Axial spondyloarthropathy.
Yeah, fab. So that's really good, actually. Much better than my first try, I think. So axial spondyloarthropathy, it is a mouthful. I'm going to shorten it, AXPAR or axial SPAR. So axial spondyloarthritis, axial spondyloarthropathy is an inflammatory arthritis where the main symptom is inflammatory back pain. So it's an autoimmune condition. And I'm not really going to go into a great detail on the pathophysiology. However, sorry, I'm just changing my view here. There are some nice, there's a nice bit of information on the first link and then a YouTube link as well there for you to have a little look at. So our challenge really here is the differentiating between inflammatory back pain and mechanical back pain. My aspirations, our aspirations over at Barkinghaven and Redbridge is to really develop, and this is why I'm here doing a teaching session, hopefully to GPs, primary care AHPs, secondary care people as well who've got who deal with these patients. So I'm hoping we can start today. I don't want to look at it or see it as a one-off session. So I'm hoping we can start to develop a bit of a long-term working relationship. We want to be able to support referrers to identify inflammatory back pain early on and develop our pathways to receive and effectively assess and diagnose these patients. So we want to look not just at primary care, but developing stronger links within secondary care and targeting all therapists, all AHPs, all doctors who have a higher potential of having contact with patients with inflammatory back pain, so that you're aware of the signs of symptoms, you're aware of all the extra signs and symptoms, you're aware of the unusual signs and symptoms, and so that we are enabling you to refer these patients on early. So we, of course, want to improve patient experience. And the key thing here really is that we're aspiring to reduce the delay to diagnosis in axial spondyloarthropathy. So I'm going to, with the chat now, I want you all to just have a little go at answering each one of these questions. So if you were a patient with inflammatory back pain, can you just put one and then yes or no to each one of these answers? I just want to get a little bit of a feel for what your background knowledge is here. So in the chat, just put one, yes or no, two, yes or no. Has your back pain been lasted more than 3 months? For 3, yes or no. So just start popping some yes or no's in the chat. Put the number of the question and yes or no if you can. So not got any yet. Anybody there? Doesn't matter if you're right or wrong. Yeah, just pop in something. No answers. Come on. Not necessarily. Oh, I like it. Yeah. Okay. So 2, yes. So you can just put Y or N for 2, Y or N for 3. Oh, lovely. 1. No. Yes. 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 Or yes. And if you don't know, just pick a question that you want to. Yeah. Be a cute answer. Yes. 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 So lots of yeses. They're not all yeses, but most of them are. Yeah. 4, 6. Yes. Good. 4, yes, lovely. 4, yes. Okay, so we're getting all coming in, lovely. I'll just wait. 7, yes, yes. 1, 2. Oh, what's that? Lovely. I like that one. All the answers in there. 4. Okay, cool. 5, usually a bit. Great. Okay, so I'm getting a bit of a feel. 6, does it improve in your rest? No. Lovely. Could be mixed. Yeah, good. Okay, nice. Thank you for joining in with that. That's great. So what is this? This is a tool to help you build your suspicion, to help inform patients of whether or not they might have inflammatory back pain. And it's really a may. Will you? Do you? Could you possibly? This gives us a bit more grounding as to what your symptoms are. So NAS have done a lot of work recently, and they've released a brand new website, www.actonaxialspa.com, and there's a symptom checker on there. So these 8-point symptom checks where patients can go on and answer these questions and get a report back, which might suggest that they bring this to the GPs to explore further to see if they've got inflammatory back pain. So the answers to these questions, all of them are a yes, apart for inflammatory back pain, all of them would often be a yes, apart from number 6, does your back pain improve when you rest? Often inflammatory back pain doesn't improve when you rest, but everything else, yes, it does. And I'll bring that out throughout the presentation. So I'm moving on. Identifying inflammatory back pain, GPs, primary care practitioners, FCPs, physios, osteopaths, you have a huge exposure and experience in managing patients with persistent back pain, and you're critical in helping to reduce this unacceptable 8.5-year average delay to diagnosis. So yeah, you heard that right. On average, people with inflammatory back pain, so axial spondyloarthritis, it takes 8.5 years for them to be diagnosed. And that's not just in the UK, that's not just in our borough, that's across worldwide, really. There are some countries that have got it down to about 4 years, and I think there's maybe one that's got it down to 2, but on average across the world, it's an 8.5-year average delay to diagnosis. So thinking about how many patients you might be seeing with this, there's estimates that approximately 5% of patients presenting with chronic persistent back pain will have inflammatory back pain. So 1 in 20 of your back pain patients may have inflammatory back pain and require referral to rheumatology. But not all patients eventually diagnosed with axial SPA will be fitting that textbook definition, which is already complicated and difficult to diagnose. So presentations of symptoms can be really, really variable. So depending on how long the patient have had poorly managed inflammatory back pain, they'll start to also seem to fit a mechanical pattern or a more sinister pattern. So I'm going to try and guide you a little bit on how to be confident in your suspicion that this patient has the inflammatory back pain and needs a referral onto rheumatology to explore if they have axial spondyloarthropathy. So inflammatory back pain is not the only one, but it's one of the most common symptoms of axial spondyloarthropathy. And so let's look at how it's broken down and what the different parts of this great big long word really mean. You've got your non-radiographic axial SPA, and this is where you have signs of inflammation on MRI. This is a new thing, like relatively new, it's over 10 years. So, but previously, I think one of the reasons why one of the reasons why it takes so long to diagnose axial SPA is because the radiographic changes take time to appear. So within axial spondyloarthropathy, you've got your non-radiographic, which is where you're finding either clinical signs or more objectively inflammation on an MRI. And then the radiographic side, radiographic AXPA, is where you've got sacroiliitis on X-ray or spinal changes, which are ankylosing spondylitis, which is where you're getting the spinal fusion. So that's kind of like the spectrum of the disease, and we're encouraging people to start calling it AXPA or axial spondyloarthropathy, as opposed to ankylosing spondylitis, although obviously use that if that's what they've got in the radiographic stage. So just a little bit off this slide, can you pop an answer in the chat to, do you think these patients get better with rest? I'm going to be repeating some of the themes, so I'm just checking in, making sure you're happy. So 8, no, yes. So do patients with axial spondyloarthropathy or inflammatory back pain get better with rest? No, great, yes, fab. You're listening, fantastic. So back to terminology, bear with me, I'm just gonna pop back up. So back to terminology, these patients generally we're presenting within kind of the rule of 3. So we've got 30% or so of patients with axial SPA that present with non-radiographic. So this is where it's showing either on MRI or not quite yet clear enough on MRI, and you're getting positive inflammatory signs on your MRI scan, but it's non-radiographic. So the X-ray is clear. There's nothing on X-ray. There's no sacroiliitis on X-ray, but you've got inflammatory signs on the MRI. So that's bone edema, your erosions, or your fatty deposits. Then the other 2/3 of axial SPA tend to be where you've either got radiographic disease, so you've got your sacroiliitis on your X-ray, or you're getting your ankylosing spondylitis and sacroiliitis on X-ray. So they're the 3 parts of the disease. Call it axial SPA. Yeah. Bear with me. Sorry, I'm struggling. Slide not go down. Cool. Okay, so this slide might be a bit repetitive. It covers the whole spectrum. Ankylosing spondylitis is defined on X-ray changes to the spine, but stop thinking about it just being that. You've got axial SPA, which looks at the patients, a wider net of people with non-radiographic changes, but symptoms seen on now with recent developments in MRI, they're identifiable on the MRI. But the key thing here, and really important, is that it needs to be the MRI run on the correct protocol. So it looks at the SIJs, or it looks at the whole spine and the fatty corners, but we're looking for inflammation. So we need a stir sequence. We need to compare that to a fat suppressed MRI and then an anatomical MRI. So we really do need an MSK specialist MSK radiologist. So and also the SIJs, they're slightly more oblique, so your axial scans won't necessarily pick up the changes. So you may have had an MRI for this patient that's been done to come back negative, but it could be a false negative. So patients present with a variety of symptoms, but the key feature for them is persistent or recurrent back pain with an onset less than 45, but this is really a young person's onset. Yeah, so don't think of this for someone in their 70s or 80s. You know, we really don't want to be seeing these people referred in for rheumatology, because we maybe missed the boat with them. Okay, obviously if you've got questions, then come in to us, but it's really a disease of the young. So it's back pain in the young population. That in itself is a red flag. Yeah, so think young patients. These are people who, if left undiagnosed, they do have a real chance of ending up with spinal fusion, ending up with problems that will affect their ability to build relationships, find or stay in work. So if we can get them early on, then we can really help these people to have a better quality of life. Okay, so back to the chat. What are your thoughts in terms of whether or not this condition is more common in males? Yes or no, more common in males? Just a few answers in the chat, go on. Yes, 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 yes. Keep it going. Yes, yes, yes. No, Esther says no. Anyone else saying yes or no? Good. Okay, yes, no. Peter says no. Lovely. Go on, keep your answers coming in. No, no, no. Yes, yes, lots of yeses. Okay, right, so on to the next slide and I'll answer. Keep you hanging for a bit. So the key points here, and I think you might feel like I'm contradicting myself at times, because I'm saying don't miss it, spot it, but at the same time I want you to be really sure. So I don't want you to refer anyone who's got problematic back pain, obviously. So there's 2 key things really. In the young, especially your 20, 30-year-old patient group that are coming in with a back pain, male or female, obviously rule out your more sinister pathology, your red flags. But this is a red flag. Have this as a background diagnosis. So have it as one of your bubbles, one of your thought bubbles. Could this be inflammatory back pain? Don't refer all back pain, all problematic back pain through to rheumatology unless you've got a high suspicion of inflammatory back pain. So you'll keep hearing me going, don't miss it, but don't send everyone to us, because we all know what that does. It creates longer waiting lists, and then the people who we need to see that need urgent care, they won't get it. So it's a red flag. We talked about that. It's not as urgent as other red flags, but if left untreated, up to 50% of patients diagnosed with axial SPA will go on to develop a spinal fusion. It affects the young, as I've said, at early stages in their life, and it affects women as much as men. So well done on the nose earlier on there. Only 5% of patients with low back pain have inflammatory back pain, but it needs to be one of your differentials. So how do you identify early and refer the right patients urgently over to rheumatology for them to get them on a good treatment regime that stops the risk of spinal fusion developing? So as I said, they're not as urgent as other red flags. So don't think, oh, great, rheumatology, that, you know, if not, they'll have a scan, it'll show other things up. Where they may sit, if there's too many referred in, they'll sit on our waiting list. So it's not the place for your super urgent red flags. Get them in the right pathway. Don't refer to rheumatology unless you're confident in your suspicion. As we go through, I'm hoping that you'll feel really nice and confident to refer in and know how to refer in as well. Yeah, okay, I won't over labor that point. Recognizing AXPAR. So top tips for you. Consider the inflammatory back pain history. I think that's a really big one. Obviously, it's our most common sign of axial SPA. But patients may present with mechanical type pain, so low back pain, radiating buttock pain, sometimes even thigh pain or anterior, posterior pain, anterior or posterior to the knee. Now, the patients, they will, if your patient presents with more than 3 months history of back pain and they're under 45, especially if they're significantly younger, ask about when their first previous episodes of back pain are. So think young, recurrent, insidious onset. So there's no reason for that pain developing, no apparent injury. So could this be inflammatory? Yeah, your thought bubble needs to be AXPAR, but you build up your index of suspicion. So it could still be mechanical back pain. So what we find is often axial SPA patients will experience multiple episodes of back pain, which may come and go. They do a bit more exercise, it settles down because they shift the inflammation, or they're taking anti-inflammatories. They might be on a dose of naproxen. That's really helped. It can be really, really effective in just 24 to 48 hours. So you might then think, okay, it's the natural healing process. It's a mechanical back pain. But actually, if they keep coming back, you've got your intermittent episodes or flare-ups and the young, then you need to be thinking AXPAR. So next question, ask about sleep. Indication, night pain's a really good indication of inflammation. So not move, especially second half of the night. If you're not moving. So when you're not moving, your inflammation can pool around the tendons and ligaments and nerve endings and cause pain. Often these patients find that they're then unable to get back to sleep. They maybe have to get up, move around, take painkillers. So these are all little alarm bells for you. Is it inflammatory back pain? So it can give a good indication of the nature of the pain. Okay, so this is one I wasn't sure what to put in, so I'm going to stick it in the chat. So alternating buttock pain. What first thing comes to your mind? Need more information? Do you think neuro? Do you think inflammatory? Answers in the chat, please. Need more info? Did you not get a little thought bubble? So alternating buttock pain. I always think, how far does it go? So sacroiliac joint pain generally doesn't refer below the knees, but this is a really common descriptor for inflammatory back pain. It's that alternating, sorry, I lost the slide there. So it's your alternating back pain. I said that wrong. Alternating buttock pain should always raise a suspicion of inflammatory condition. And your SIJ is often your culprit. Yeah, so this moving pain for me always raises the question of, well, if it's not one specific joint, ligament, tendon, that's a problem. Why is it moving? Why is it moving around? Is this inflammatory? So they're just little thought bubbles. Okay, moving on. My slides won't move, just bear with me. Okay, cool. So next tip, consider their response to anti-inflammatory. So if you've got an inflammatory condition, thoughts are it should respond to an NSAID. So if they've tried NSAIDs, do they help? Do they get an effect within 40 hours a week or so. Obviously, some patients won't take them. Your asthmatic, your cardiac patients may not be able to take these. So if you're not a GP, think about sending the patient into GP to see if it's safe for them to take an NSAID. Could they try it? If GPs haven't tried them on the NSAIDs, it's really useful bit of information. So if they're coming to rheumatology and they've tried anti-inflammatories and they're just not working, not optimizing their pain, not helping enough, if they've tried and failed 2 anti-inflammatories, then we can start looking at whether or not they could go on to biologics. So they need to fail. Nice guidance suggests they need to fail 2 NSAIDs before they can be trialed on biologics. So if they're safe to try, get them on them. The guidance, nice guidance, it's nice guidance 65. I'll bring up an image of it later and links for you there to come into that if you need. 2 weeks trial on an anti-inflammatory, so the lowest possible dose. So don't need to go straight to naproxen. Try them on the off-the-shelf ibuprofen, Nurofen, a couple of weeks. Okay, next question then. So chat question: if you have a patient coming in, knee pain, tennis elbow, heel pain, would you think this might be related to axial SpA? Answers in the chat, please. So yes, yes, yes. Thank you for contributing. Keep going. Anyone else? Pop your answers in. Really doesn't matter either way. You'll know for sure in a minute. I'll give you the answers. So yes, yes, yes. Yes, yes, yes. Any more for any more? Any more yeses? Any more no's? Okay, yes. Fab. Yeah, great. So we've got other MSK related symptoms of axial SpA. So it's not just inflammatory back pain. A common one are your tendinopathies, your enthesopathy. So this is an autoimmune condition that affects the tendons and the ligaments around the joints. So your plantar fasciopathy, your Achilles tendinopathy, your tennis elbow, your golfer's elbow, your shoulder problems, neuropathy, all of that can be a cause of inflammatory arthritis. So peripheral joint pain. So I think of your 3 MSK associated symptoms. Excuse me, inflammatory back pain, your enthesopathies, your peripheral joint pains, especially if these pains move around. Yeah. Okay, next question then. Answers in the chat for me, please. Do you think eye, stomach or skin trouble might be related to axial SpA? Yes, 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 inflammatory, yes, 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 yes. Okay, you know all this, so hopefully I'm not teaching you to suck heads exactly. There are extra-articular signs of axial SpA. So the key ones, you've got your acute anterior uveitis. So we need to target ophthalmologists to get them to refer their inflammatory back pain patients over to us. Yeah, so the key one as a condition that would present with patients with inflammatory back pain is your inflammation in the eyes, your acute anterior uveitis, but also skin, so your psoriasis, your inflammation within the skin, but also inflammatory bowel disease, so your ulcerative colitis or your Crohn's. Patients may also present with swollen fingers, although that might indicate other things. It might normally lead you more down the rheumatoid arthritis route, but it is one of the symptoms that are commonly reported in axial SpA, and your enthesitis. So they all are extra-articular manifestations. So you're building up your inflammatory picture. Presence or absence of these conditions could indicate a patient's back pain might be more inflammatory. So I've seen that question. That's fine. That's a great time for that to come in. So plantar or Achilles issues, they could be either. They wouldn't necessarily need to be bilateral, but you might find they can be bilateral or unilateral. So there's no definitive bilateral unilateral presentation for these patients. Often with your psoriatic arthritis, so your psoriatic spondyloarthropathies, the findings tend to be unilateral, but with axial SpA it doesn't necessarily fit that picture. Swollen fingers may or may not be persistent generally, but if their inflammation is not well managed, then the swollen fingers will persist. Yeah, but okay, will improve with movement. So often that's the case, depending on how bad the swelling is. So I'll carry on. For example, You get your patients, they've got a one-off knee effusion or an episode of anterior uveitis and some gastrointestinal infection. They might be really useful when questions to ask when you're looking at this back pain patient. So next question then, what aspects of family history might raise your suspicion of axial SPA? What might you ask for family history? Any ideas? Go on, just brainstorm, chuck a few words in the chat for me. Autoimmune disease within the family, yeah. Other autoimmune conditions within the family, yeah, exactly. Anterior uveitis, psoriasis, IBD, so inflammatory bowel disease, not your IBS, but your IBD in the family history as well is quite significant. So moving on, all right, just bear with me. So tip number 6, ask about family members. So think about the close family links. Do they have axial SPA? So really, if you're doing a virtual clinic, you don't get the benefit of their father with axial SPA, with spinal fusion, incredible kyphotic upper back posture. You don't get the benefit of seeing them, but ask for family history, and it can raise your probability. I've asked this before, but answers in the chat, please. Is AXPAR common in females? I really want to try and hit this home, yeah? So hope answer both, yeah, both. It is definitely present in females, good, same commonality, fantastic, great. Okay, so moving down, tip number 7. So I really want to dispel the myth about it being more common in men, but I recall at uni, we were taught this is a young man's disease, but that's not the case. So historically, axial SPA was considered predominantly male, and that's probably because we could see it on radiographic, we could see it on the x-rays. And the findings have shown that it is actually radiographic signs of AXPAR is more common in men. However, with the advent of MRI, we found that the non-radiographic inflammation shown on MRI is actually more common in women. But that doesn't mean men have got it worse. It just means because evidence has also shown that the burden of the disease is exactly the same, whether you've got radiographic changes or you've got your MRI inflammation. So clinically, in front of you in your clinic, both these patients have the same amount of pain, the same amount of burden of the disease, difficulty staying at work, night pain, struggling. Mental health issues are often really common with this client group just because it's so difficult to get a diagnosis, and the pain impacts on all aspects of a patient's life. So it's common, just as common in females. So the key take-home message is that if the x-ray is clear, don't rule it out, and especially don't rule it out if it's a female. I mean, men still have the non-radiographic as well, but if you've got a woman, then your index of suspicion is going to be higher. And again, I'll say it again, the disease burden is just as bad in both, and the outcome with biologics is just as good. So next question then, what tools can help you be confident in your suspicion of axial SPA? Any ideas, tools? I don't know if anyone attended the teaching session on CPN that we ran in November 2019. I stuck my head in at the end and recommended one of the tools. I don't know, is anyone using them? Let's have a look what he's telling me in the chat. Oh, fabulous. Yes, the 8-point symptom checker. Good. Yeah. Do you use it, Sabine? Anyone using the NAS symptom checker? Yeah, I thought you might say that. I'm hoping that this will become more widely used. NASA driving forward with a big media coverage at the moment. They're playing about with the term, the name axial spondyloarthritis, and they've got some big comedians doing some video clips on pronouncing the word. So hopefully you'll start to see some things. There might be some media drive on bus stops, and it'll be targeted in little parts of the country, and if affected, rolled out throughout. So there's lots coming from NAS. And again, while we're on the topic, NAS have in July released their gold standard to diagnosis campaign, where they're trying to bring this 8.5-year delay to diagnosis right down to 1 year. They've got an all-party parliamentary group, and they're lobbying Parliament. They did so before lockdown and before COVID problems, and were promised that they would be given a hearing on axial SPA and ways to try and bring down this delay to diagnosis. And NAS have been working hard. They've got lots of funding, so there's money going in to promote and increase awareness. I'll come back to NAS work in a minute. So great, yeah. Tools, let's have a look. Sorry, I'm forwarding. Okay, so we've got the 8-point symptom checker. Act on axialspa.com. That's your website, and it focuses on what patients feel. So those 8 questions that we looked at the beginning. NAS have also developed this nice little acronym, and they've gone orange. So their inflammatory back pain is now orange. Breast cancer is pink. Macmillan's green. Yeah, inflammatory back pain is orange. So the really nice acronym. 5 letters. Symptoms start slowly. Pain in the lower back. It's not only the lower back, it's upper back. It can be neck as well that you get inflammatory changes, but commonly in the lower back, pelvic SIJ region. Improves with movement. That's a key one. Nighttime waking, but also you get the key thing is this early onset. So the NAS website, I'm just going to promote it a little bit here because there's so much work that's gone into this. Is this new Act on Axial SPA website is one of the only websites of its size and wealth of information. There's a section for healthcare professionals and there's a section for the general public. The symptom checker allows patients to go in and print a report that they can bring to their GP or their AHP to say, okay, I think I might have this. Can you explore it in a bit more detail? The healthcare professionals section, it's got talks from GPs, from rheumatologists, from radiologists, from physiotherapists, advising you on how to spot this, what to look out for, how to treat this. So it's really, really nice resource. I can't speak well enough of the work that NASA put into this in the last year. They've been amazing, especially with all the challenges that we've had of late. So there's some links in there. When you get the presentation, you should be able to click on those links. If not, just Google search and all the details are there for you. So patient presents to you with their little printout from the symptom checker and saying, I think I've got inflammatory back pain. Have I got axial SPA? Can you investigate further? You'll be, okay, do I refer to rheumatology? What else can you do to build your index of suspicion? There's a really lovely, more on the symptom checker there. So there's a really lovely tool that was devised by, hang on, I'm going to go back, Royal National Orthopaedic Hospital, National Rheumatic Diseases and Bath, the Royal Bath Hospital. So it's called the SPADE tool. So it's a spondyloarthritis diagnostic evaluation tool. And it looks at more, as you will have gathered, there's lots of different signs and symptoms, and not everybody will obviously have all of them. So you're building a picture all the time. You're building up your index of suspicion. And these algorithms, the 8-point checker or the SPADE tool, are really nice ways to go, okay, how much of this is enough for me to refer to rheumatology? So the SPADE tool is a quick and easy resource that you can use to help determine whether or not you should refer on, or maybe you want to explore other things first. You can go onto a YouTube link that's got wonderful specialist rheumatologists in axial SPA talking about the SPADE tool and how it's been developed and how it should be used. And this tool focuses on your MSK signs, not just what patients feel, so not just the felt signs and symptoms, but all of the things we've talked about so far. So your MSK signs, the 3 things there that we talked about, your 3 extra-articular signs, family history, and it also asks if they've had an MRI and if they've had the HLA-B27. So I'll talk a little bit more about HLA-B27 in a minute, but on we go. Okay, fab. So when you Google the SPADE tool, this is what I always get up. It's not this one, it's this one that you want. And it's your spondyloarthritis diagnostic evaluation tool. And just some prompts. They're the questions in there. You tick the questions, you submit, and it will tell you this tool. So with the 8-point symptom checker, it's either yes or no, you may have inflammatory back pain. But with this tool, you get levels. So there's an algorithm in there. I'm still trying to get hold of this so that we can try and look to put it in our referral form that when you send someone you can use. We're not that close, we're not there yet, but the algorithm within this isn't as straightforward. So the 8-point symptom checker with NAS, you just need 5 positive answers, not necessarily yes, but 5 answers relevant to the condition. Basically it's yes on all of them apart from do they improve with rest, 5 of them, and then you'll get possibly this is inflammatory back pain. Whereas for this tool, this builds up a picture. So unlikely. So this is quite nice. If you're like, well, I'm not really sure, but I'll check unlikely inflammatory back pain, you'll get additional tests that necessary, or you'll get definitive, really, really likely to have inflammatory back pain. So it helps you build this index of suspicion. It helps you decide whether or not to refer these patients over to rheumatology. There's another one here, which is a really nice tool that's been developed on, this is more for knee pain. So it's developed by someone looking at whether or not there's other things to think about with knee pain. Is it inflammatory? So is it psoriatic arthropathy? Screen them. So SCREENDEM, and it covers similarly the things that we've talked about. So skin, psoriasis, colitis, Crohn's, IBD, so inflammatory bowel disease, family history, eyes. Are we getting inflammation in the eyes? So this anterior uveitis obviously won't resolve with your antibiotics. They need urgent steroid input to settle that down. Early morning stiffness is your next I've not talked about nails. I've talked about swollen fingers. We've talked about enthesitis, and we've talked about the movement, the medication effect. So if you like your little tools, or you want to stick something up on the wall, there's some things there that you can use. Obviously, the NICE guidance, everything I'm talking about is underpinned by the NICE guidance, how you diagnose, when you raise your index suspicion. There's really nice sections in the NICE guidance on those patients who you're looking, but nothing's really coming back as positive. So it may be that you send a patient into rheumatology, or you have done already in the past. We can't find anything inflammatory. They might get a bit of physio input where we teach them, we give them some advice on self-management strategies in absence of inflammatory disease, but the treatments will often be given to support inflammatory disease as well if they clinically present as inflammatory, but we can't find anything. Then if there's nothing found for the rheumatologist to treat medically, they'll often get discharged, and then there's an open door really. Sometimes the patients, when I talked about the MRI, signs on MRI, there's a small group of patients, I'll take you back. So there's a small group of patients who have the clinical signs, but the MRI changes won't yet be there. So can you see where my cursor is? Down here in this little bottom corner in the non-radiographic expert, you may get patients who come in and they're clear for, we can't find anything. Bloods, I'll talk about bloods in a minute, but there's no signs of inflammation on your MRI, on anything else, fingers, feet, toes, hands. Generally, rheumatology will have a look and rule all of that out. So they're still presenting clinically. We can't treat, we're discharged with physio advice, management, exercise management. But they may come back, and there's a study being done by our specialist MSK rheumatologist who looked at patients presenting with really mild sacroiliitis on MRI, so not definitive for axial SPA. When they're looking at the MRI scans, you need to have the inflammation showing on a few slides, or really big areas that are definitive and in the right spots for it to be suggestive of sacroiliitis. And if that's not present, but there's just mild symptoms, the study that our radiologist did was just re-scan these patients after 6 months, and she found that at least 50% went on to develop a definitive signs of sacroiliitis. So if the patient comes back to you and they've been ruled out for inflammatory stuff by rheumatology, but they're still presenting clinically with all of this, really raising your index of suspicion, they're struggling to manage their symptoms, then by all means refer them back in. Okay, so, and they may need a rescan. There were some studies done by Rajsingh Gupta and his team. So Carl Gaffney, who's also one of the rheumatology specialists and works closely with NAS, and they looked at whether or not it was useful to regularly re-scan patients. And this is where HLA-B27 is quite helpful to guide that decision. Studies found that generally those ones that would be more indicative to be rescanned would be males with a positive HLA-B27. So that's where the genetic markers might be helpful in planning whether or not they've got a potential to develop into inflammatory back pain where it's not been found to date. Yeah. So let me get back to where we were. How far did we get? So NICE guidance. Okay, brings me on to so far I've given you 9 top tips, but at this point I'm just going to talk a little bit about when you refer to rheumatology, what would we like you to send them in with? So not much really. We're happy to arrange the MRI. When they come to rheumatology, we'll request the MRI because we really want to make sure, and there's a bit of body of work being done at the moment, making sure these patients get the right MRI protocol. So our specialist MSK radiologist is going to do a little bit of work with NAS. They're doing a spotlight series on publications, radiology publications that guide what MRI sequences should be. So there's a nice protocol being developed. We follow that and a bit more actually. So we're looking at whether or not we don't need to maybe do quite as much, but it's key that we get a specialist MSK radiologist or a radiologist skilled in looking for inflammatory back pain and diagnosing that from the MRI. So don't need to get an MRI before, we're happy to do that, but it would be helpful for patients to have had routine bloods done. You'd probably generally do this anyway if you're querying someone up for inflammatory back pain. So routine bloods, FBC, using renal function, include your inflammatory markers. Now, renal function, because we want to know that it's safe for them to take anti-inflammatories and what next stages we might be able to move them on to if they're failing the NSAIDs. Are they safe? Kidneys, liver, can we give them medication? Then inflammatory markers. So I say include CRP and ESP, I've put there, sorry, ESR, that should say. Include them. However, they're not usually significantly raised in axial SPA. So I'll say that again, CRP and ESR are not usually significantly raised in axial SPA. If they are significantly raised, it should really lead you, there's obviously inflammation present, but it should lead you, I think, to consider another diagnosis, because it's not a definitive test, but it helps build your suspicion, rule things in, rule them in and out. Okay, you don't. Do we send? Yeah, we're not expecting any primary care bloods to come in with an HLA-B27. We know they're specialist requested bloods. Do we test routinely for these? No, not necessarily. It's not diagnostic for axial SPA. A large proportion of people with axial SPA will be positive for this test. So I've got data here on Western Europeans. So sorry, I don't have all ancestry, all population, sorry, all ethnicity groups data, but for white Western Europeans, 8% of the population will carry the HLA-B27 gene in comparison to 70 to 90% of individuals who have axial SPA. So general population have 8% have the HLA-B27 gene, whereas if you're looking specifically at the population who have been diagnosed with axial SPA, 75 to 90%. So it is prevalent in the axial SPA group, but there are 10 to 25% of people who have axial SPA and don't have the HLA-B27 gene. So, and of those 8% of people, studies have been done looking at what the chances are of them going on to develop axial SPA. So it's only 1 in 15 will go on to develop it. An interesting study was done by, I believe it's Carl Gaffney, one of the consultant rheumatologists, again, does a lot of work with NAS. And they looked at patients and I might have got the wrong person there, but the teams looked at presence of HLA-B27 in Gambian population and whether or not they went on to develop axial SPA, and much lower numbers in the Gambia compared to Western European countries went on to develop axial SPA, so less than 1 in 15 developed it. So there's thoughts that there is more than just the genetic link, so there's some other environmental trigger, and there are starting to be studies looking at whether or not diet has an influence, but there's not strong enough evidence yet to encourage or recommend dietary changes at this stage, but there's lots of new research kind of being encouraged at the moment with regards to that. It's thought that over 100 genes are now thought to be involved with axial SPA, with HLA-B27 just being responsible for about 25 to 30% of genetic risk. So that's really my interest. I've put that in. I've added quite a lot to it, given that we don't really request it, but it's interesting. You know, it's useful, like I said, for men who don't show, young men who don't show signs, inflammatory signs. If they've got positive HLA-B27, there's a higher percentage chance of them going on to develop axial SPA. So we may re-MRI them more quickly than we might somebody who doesn't have those characteristics. Okay, so last top tip on how to support, diagnose axial SPA early on, try and help to reduce this delay to diagnosis. So know us. Hello, Rheumatology. We're here. I'm your local rheumatology physio, part of a much wider consultant rheumatology team, clinical nurse specialist rheumatology nurses. So we are here referring your patients. Know your referral pathway. So at the moment, you're still in refer by paper. There's some work being done on improving e-referrals. Try and make things easier for you to refer in. Make sure that you mention suspected inflammatory back pain on your referral, and then we'll triage these patients as more urgent. Our ambitious aim for axial SPA or query inflammatory back pain patients is to try and see them within 3 weeks of referral, but this really does depend on you doing the pre-screening. So if you're sending in people who your suspicion isn't that high, then we're going to get much higher numbers, so we're going to struggle to meet our 3-week goal. So just refer in if you've got a really high index of suspicion of inflammatory back pain. Otherwise, your back pain patients need to go somewhere else. Maybe it's physio, maybe it's neurology, maybe it's treat obviously red flags as you would. So high index that your back pain is inflammatory, excuse me, send them to rheumatology. We'll do the MRI scan. If you can get the bloods done beforehand, that'd be fantastic. How can you be confident, just to summarize, that your suspicion, that you've got high suspicion, so get patients to do the 8-point checker, use your SPADE tool, and then use my email. If you're getting themes or you're struggling, I'm not encouraging you to ask me questions about every patient. I only work Mondays and Thursdays, so I just wouldn't be able to manage a question on every patient that you've got. But if you're getting themes, then please do email me, build up your themes, send in your feedback, send in your questions. I'll welcome any feedback after today's presentation as well. So that's it for me. Over to you. Ask me any questions and I shall do my very best to answer. And you can unmute and ask, or you can put them in the chat, however you prefer. Hello, we're here. Is there anyone out there? Drop me a note in the chat. Any questions?
I'm going to stop recording, so it might maybe encourage more discussion. So yeah.
Fabulous. Okay, so have I